This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is the Group Room, making our 15th appearance at ASCO and one of our very best. Joining me now is Dr. Eduardo Bruera, Department Chair in the Department of Palliative Care and Rehabilitation Medicine in the Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center in Houston. Hello, Dr. Bruera.
Hi.
What does it really say about our culture, our perception of illness, dying? It's so interesting that while death is the one guarantee we have in this life, no one is going to survive life. It's impossible. We're all going to die. At the same time, it's one of the most avoided, feared, mysterious, silenced areas of discussion. I don't know now, you have Italian and Argentinian roots. I don't know how it is in perhaps other cultures, but here, what is it about our society and our values and our perceptions that are really, we become our own worst enemies? Mm-hmm. What is your experience and knowledge tell you about that?
Mm-hmm. Dying is not in our genes, it's not in our plans, and we have evolved in a way that means dying is not a great idea. And therefore, as we get an illness that is life-threatening, or as our illness progresses, we will be distressed. We will suffer considerable amount of fears, of worries. We have seen other members of our family be ill, and sometimes we fear what is going to happen to us and so on. So it is a tough consideration for almost universally all of us. But even when we were cockroaches, we basically progressively feared that moment in which our life might end, and we try to avoid it by all possible means. So when we are diagnosed with a serious illness, we get incredible amount of emotional distress. In addition to the physical distress, we get emotional distress. And one of the things we really fear is dying from this disease. So what leads us to a hospital is not the expectation of alleviation of suffering or the expectation of alleviation of pain, is the expectation of making that life threat to go away. So part of the problem is we not always want to access these services because we're afraid of dying. So part of our work with patients, families, and with our colleagues that are sending us the patients is to say that we will be there. We will not change a serious illness or dying into a non-threatening, friendly, cheerful event, because that's not in our genes. It's not going to happen. But there's an enormous amount of unnecessary suffering, unnecessary worries, unnecessary distress that we can help a lot with. It's not an easy moment for anybody's life, but it can be made so much easier than the way we imagine it could be.
It seems to be even more complex because there's the patient, and then there are all the people that surround the patient, and the values and the readiness of family members. It so influences the freedom for the patient to feel safe, to maybe engage in a discussion, to reach out for palliative and at some point perhaps hospice care.
The problem is people come to us and we have a lot of conversations with the patient, with the family separate, and then with everybody together. And sometimes we are able to facilitate a lot of conversations that are having trouble moving on. But we try to figure out what do they feel, and we asked several hundred patients and the relatives. So you were sent to this center, and we just saw you. Tell us, please, do you think you were sent too early, right about time, or too late? 85% of them said, too late. We should have been here way earlier than we are now. We're so sorry that nobody sent us here before. So I think there is this great opportunity to have these conversations much earlier. And that doesn't necessarily mean that people will forego important treatments if that's what they want, but it allows them to have that wonderful dialogue and to understand that the wife is caring for him, he's caring for the wife, and maybe the way they're caring for each other is not necessarily the most useful for both of them.
With the majority of cancer patients being treated in the private sector, in the community, who can't easily access a palliative care specialist, what happens to them? Mm-hmm. Where do they go? They're not at a cancer center where there may be a dedicated department for palliative medicine.
You're making an enormously important question. In reality, of the U.S. cancer centers, the majority of U.S. cancer centers do not even operate an outpatient department. So if that patient is an outpatient, in the majority of U.S. cancer centers, that patient would not access an outpatient palliative care doctor. And that's a huge challenge because those doctors out there and those centers are there. So it's a question of saying it makes a lot of sense. It not only works in relieving the suffering, it prolongs life about 2.5 months as compared to not receiving palliative care, and it decreases the cost of care enormously. So it makes an awful lot of sense that community oncology teams engage palliative care doctors to see the patients with them in their practices, and that cancer centers really develop outpatient supportive care centers that are accessible on the same day to the vast majority of their patients. And I think it's mostly an evolutionary aspect because this is kind of a new area. Sometimes it's not in the radar screen of oncology practitioners or of cancer centers to say, you know, this has, you know, it's moving fast and they need to catch up.
We have two challenges here. We have to educate the medical oncology community, and we have to educate the public.
Yes.
I'm very grateful that you took time out to spend with us today in the group room. Dr. Eduardo Bruera, Department Chair, Department of Palliative Care and Rehabilitation Medicine in the Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center in Houston. Thank you so very much.
Thank you. Thank you for having me here.